Welcome everyone. I appreciate you guys coming. My name is Ashley Mckinney and I currently work at Mentor Behavioral Healthcare. I started, hold on, I'm actually printing out my notes here. Not that I'm doing anything last minute or anything. So I got my bachelor's degree from Furman University. Go Paladins, and then I came straight to Boone and got my master's degree in clinical psychology from App, and I started working as a psychological associate in I think 2005, and I worked at New River Behavioral Healthcare under the supervision of Murray Hawkinson. So he ended up being my supervisor for quite a while. And I feel like I really benefited from that. It was really neat to see him participating in WCCI when I started doing that also. So when New River went belly up, I was very fortunate to get a job at the CAC in Boone, and which is the CAC of the Blue Ridge. I got hired as a therapist there, or a trauma-focused clinician, and I went through a rostering process right before I got hired there to get certified in trauma-focused cognitive behavioral therapy, and that is through the North Carolina treatment program. So I'm going to show you their website because they work on training a lot of therapists in trauma-focused treatment. And that's a great resource to use in looking for a therapist who can treat trauma, especially for children. So I started working part-time for Dr. Hank Schneider at Mentor Behavioral Healthcare while I was working at South Mountain. And then I had the opportunity to start working there full-time, and then my husband and I purchased the business from him when he was ready to retire and move to the beach. So we've owned the business now for about 2 years, running it from home pretty much at the time, but normally we're in the office a lot more. My husband, Craig Mckinney, actually provides sex offender treatment. So he performs those evaluations and has a group that he runs, and also provides individual treatment for registered and convicted sex offenders. So it's very interesting, it's kind of an interesting dynamic because I mostly treat children, a lot of whom have been traumatized. So we make sure that when the, pre-pandemic, we are seeing our clients at different times. We have to kind of coordinate that to make sure they're not in the office at the same time. Normally I see most of my clients in the afternoon and he sees most of his in the morning, so it doesn't usually overlap. But if anybody has any questions about sex offender treatment, I would be happy to attempt to answer those. I don't provide that and I'm not trained in it, but I do get to kind of witness him doing that. And it's definitely a very specialized kind of treatment that does require training. It's not something that's easily generalized from, oh, I treat addiction, now that's sort of like an addiction, so I'm going to treat sex offenders now. It's definitely something that needs to be specialized and specific to that. And it's pretty interesting. He enjoys the work, and it's a great thing to provide for the community to try to help make the community safer also. And
Ashley,
so anyway,
I was just going to say real quick, I actually did a paper on that in school and went into it with a lot of judgment and kind of felt like that was the pervasive perception of sex offenders in general. And it was very interesting to me, number one, how much trauma sex offenders had experienced typically in their childhoods. And then number two, that there's a wide range of motivation or intent, or that's not even the right word, but behind that type of behavior. And so, it's not always, I don't know how to say it in a way that doesn't sound like I'm trying to make excuses, but it was just very interesting to me what I learned about that. And so I wonder if he might be willing to come and talk with us one day in the spring, perhaps, about it more. Because I think
Keep
it's
working on
definitely,
them, and I'll try to persuade
okay.
him to do that.
I definitely think it's something that you could easily spend an hour just talking about, when you're trying to understand things from a trauma-informed lens, that is, an area, both victims and perpetrators, that
Mm-hmm.
where there's a lot of trauma.
Yes, yeah, it's definitely a very important component that a lot of people don't really know a whole lot about, which isn't anyone's fault. But it's not something that comes up in everyday conversation, even for a lot of therapists. I was fortunate enough when I worked at New River. I actually did a practicum and partial internship there, and I got to work a little bit with Ray Powers, and he was a sex offender treatment provider also. And he loved getting women to come into his group, just to kind of make the participants, expose them to that, so they could, kind of be led by a female instead of a male. It's just kind of a different dynamic.
Yeah, very interesting.
But I didn't get to, yeah, I wasn't able to participate in his group very much, but I did help him. I did a component of his evaluations. And in addition to providing trauma-focused therapy and treatment to children and adults, in addition to other types of therapy with Mentor, I also do evaluations, and mostly psychological evaluations like IQ tests. But Craig and I also work together on completing parenting evaluations most of the time for local DSSs, Department of Social Services, in different counties nearby. And I also Ray Powers trained me in doing just the mental health component of an assessment for a sex offender evaluation. And I do that there's another sex offender treatment provider in Asheville who I've worked with before, and I also help her with that. Since those particular types of tests require someone trained in psychology like myself, I will do that component of it for her while she does the interview and a lot of other types of assessments and that kind of thing. So it's kind of, sex offender evaluation is kind of a science with lots of different types of assessment. It's definitely not perfect, but there's a lot to know about that too. So I definitely don't perform those evaluations in full, only the personality testing, mental health component.
So one of the comments in the chat box was just appreciation to Craig for doing that and doing it so well and as part of our community. So you can pass on our gratitude for that. So I just want to make sure you saw that.
Yes, thank you. Thanks, Maggie. I appreciate that. Craig has been doing this for a couple of years, I think maybe 2 or 3 years, and it's amazing how it takes a while just to kind of get that treatment program started. So he's definitely still working on that, and a lot of the individuals, all of the individuals in his group, basically it doesn't really work unless they have been convicted and they've been sentenced in some way. And some of them have already been to jail or to prison, and some have not been to jail or prison before, but all of them have to be convicted. And sometimes it's surprising. I mean, I guess it's a good thing maybe that he doesn't get a whole lot of referrals. So he doesn't have a huge group, but it also takes several years to kind of establish that program. So he's definitely, and a lot of his group members are actually graduating soon. So he'll be ready for some new group members, although we're not gonna pray for that because we don't necessarily want, there to be a need for it. But the thing is, they're out there, and a lot of them aren't getting referred to the right kind of provider who specialize in that kind of treatment. So that's the other part of it.
Makes sense. Thanks for sharing those details with us.
Sure, yeah. But to go back to the trauma treatment, I am trained in trauma-focused cognitive behavioral therapy, and I was actually in a year-long rostering process with some staff and clinicians and professors from UNC Chapel Hill and Duke University. It's kind of a collaborative effort. So I had supervision monthly, bi-weekly from these expert individuals, and had to finish the program after having provided the treatment to at least 2 cases. So I had to provide a full length of trauma-focused cognitive behavioral therapy to at least 2 clients and then kind of talk through it and everything. So it was a really great program because I had people teaching me as I went, and I was trained to make sure we provide that treatment in the way that it was intended, with fidelity, basically, so that I'm following the treatment manual as I should, because that, I guess research has shown that the treatment's more effective if people can follow that treatment protocol closely. But to go back to, I know that a lot of folks in this great committee, or this great group, the WCCI group, are familiar with trauma, especially with ACEs and what that is. But I'm just going to review kind of what the mental health definition of trauma is. And it's an event that threatens the life or physical integrity of a child or someone important to the child. And the other component is that it causes an overwhelming sense of terror, helplessness, and horror, or a lack of control, and an intense physical response. So there might be dizziness, nausea, shaking, that kind of thing. So, and an individual can maybe experience one traumatic event, like a car accident, for example, or they might experience multiple traumatic events that are the same kind, like they might repeatedly witness domestic violence, for example. Or there's some people who, have those multiple ACEs and have experienced multiple traumatic events of different types. And those are very difficult to deal with, the most difficult probably. And neglect doesn't really meet the exact definition of trauma, but it does actually threaten the integrity some way of children. So neglect is also considered to be trauma. Like if a child is left alone in a car seat and with a wet diaper, and they're hungry and they're crying for a long time, that could be considered a traumatic event for a child. And some of it has to do with the perception, especially with children. If they were terrified in the ways I described, even if it wasn't what maybe you or I would consider a trauma, it may be a traumatic event for them. If they perceived that their life was threatened, or that the life of someone else was threatened that they cared about.
And we talk about that when we're doing that WCCI presentation, how the same trauma can impact several people differently, depending on your age, your trauma history, your gender, your birth order, your personality. And so what might not be at all traumatic for somebody, one person can be incredibly traumatic for another. And so I think, especially when we're talking to people who are not in helping professionals, like teachers maybe, or reporters or whatever, it's so important to say it's not just the event, it's also how it's perceived as to the level of trauma.
Yeah, exactly. That's right. Definitely. So if we, I guess I want to take a break for a minute and just get some feedback from the group. We're going to be talking about treatment. A lot of people are probably familiar with therapy in one way or another, whether they work with someone who provides therapy, or they've been to therapy or counseling themselves, or brought a child there. I just wonder, what are maybe some stereotypes of what takes place in a therapy or counseling office? Like, what comes to mind when you first think about that? Or maybe even, some personal experiences, or what about what takes place in a therapy office. Because, there's that door closes, and then sometimes there's kind of a mystery of what actually goes on in there. So I was just curious if anyone can share their thoughts about that, their first impressions.
So you're welcome to just speak up if you want to unmute yourself, or you're also welcome to type in the chat what are your stereotypes about what happens in therapy. And I'll say my mom is a therapist, Ashley. I don't know if you know that, licensed marriage and family therapist. And so I have, but none of it obviously didn't happen in our house, but I still had these conceived notions of what that was. And and then I've worked with a lot of therapists, both personally and professionally. And so it's very interesting, the myths and stereotypes that we have. It almost seems like a magical process at times. And so I'm interested to hear what people say. So one thing is that they ask you, how does that make you feel? My 16-year-old daughter would be like, that's not just therapists. Like, quit asking me that question. So they ask you, how do you feel the entire session? That's a good one.
Yeah.
What else do we think about therapy process?
Yes, that's very true. And sometimes I feel guilty of that myself when I keep on asking and asking, but it's hard to do. It's hard to talk about your feelings a lot, especially difficult feelings. You have to have someone ask you in order to do it sometimes.
And I don't think, go ahead. Yeah,
Oh,
go
sorry.
ahead.
I would say, this is Vicky. I would say when I think about therapy for a child, like a playhouse with the characters, dolls in there, or animals, or play therapy, like it's play and then things come out that way, or drawing, or a lot of painting or coloring, just to let them feel safe, but then to be able to express themselves. Some different tools in the office is what I imagine it to be.
Yeah, that's right. Thank you, Vicky. And there is a lot of that. And play therapy is something that has been going on for a lot longer than cognitive behavioral therapy or trauma focus, CBT. And it is a really great way to help children feel comfortable and also to express themselves. A lot of times children work things out by playing, and that's kind of how they process it rather than just sitting in a chair and talking to somebody. They kind of figure it out with play. So yeah, that's pretty accurate, I would say.
One other thing, I don't know if you saw this, Ashley, is somebody said that it's very serious and not a lot of fun.
Yes. Yes, it often seems that way, especially between adults.
Another comment was, it may be a misconception, but that I would be forced to speak directly about past trauma. So maybe not have a lot of control over how the session goes.
Yeah, a lot of people worry about that. Definitely. Thanks for sharing about that, Brittany. One thing I was taught in the process of being trained on trauma-focused cognitive behavioral therapy, which I'm going to call TFCBT because it's quite a mouthful and I'm likely to stumble over it if I keep on saying that whole long thing. But they taught us that if you're not having fun, you're not doing it right. So they really encourage creativity and how to apply these concepts and strategies in a very playful way. So I heard about ideas of, helping a child make a comic book about their trauma, for example. There's just so many, and I'll tell you about some of the different games that I play that with kids. I mean, it's really fun. I love playing, all kinds of games, Unos or checkers or Candyland or whatever it is, depending on the age of the child. And it's actually therapeutic and it's directly related to their treatment. So that's a lot of fun.
I took a training in sand therapy. I don't know if it's called therapy, but, and it was one of those things where I was really I didn't take it because I wanted to know more about it. I took it because I had to have another hour, for my thing. And so I went in with this mindset of, what could you possibly do with sand? And I went with another professional colleague from the school system. And by the end of it, I was like, they had us reenact things from our own history. And it was the most powerful thing that I had done in a really long time because it was at once fun. And who doesn't love having their hands in the sand? And it was amazing to me how quickly dynamics came out of me into the things that I was doing in the sand. So it definitely changed my mind about that type of therapy and how useful it is. I found it really intriguing.
That's very interesting. And I have a friend who had a huge collection of sand tray therapy props and stuff like that. I don't know very much about that, but I did actually have a sandbox when I worked at New River and let kids play in that while I was talking with them as well. Really, but that's really neat. That's something I wouldn't mind learning more about myself.
Yeah.
That sounds fun also.
I think those were most of our comments in chat.
I think for me, like when I think about the stereotype, I think of Freudian kind of therapy with somebody just laying on a couch, while the therapist is kind of behind a desk, taking notes or whatever. So it looks very relaxing, but also that's not really the way it works typically. And that was back with the psychodynamic style of treatment, which is, is still out there, but not quite as common now.
And you may be going to get into this later, Ashley, but if you're not planning on covering it at some point, I imagine that trauma-focused CBT is more intense than regular therapy, but that may also be a myth as well that you can speak to later if you weren't planning to do that.
Oh yeah, definitely. Yeah, I will be happy to talk about that, kind of compare it to maybe other types of CBT or other types of therapy, certainly. So a lot of times trauma, I think I'm not going to go over a lot about the symptoms of trauma unless that's something that you guys would like for me to do. But sometimes in children, it shows up a little bit differently. Sometimes there's more irritability. Sometimes there's avoidance, but people don't really know why. Like, well, why don't you want to go in the bathroom? Why can't you just go in the bathroom? And the child just shakes their head, and you don't really know anything. It's like, well, do you just not like the act of urinating? I mean, what is it? So that the symptoms are a little bit different, but often they're pretty common. But a lot of times trauma can impact development too. So it affects the way people view the world, and if they think they are safe or not, if they can believe other people and trust other people, how they manage their emotions and just respond to changes in their lives also. So I'll talk a little bit about trauma-focused cognitive behavioral therapy. That's what I know the most about, but that's definitely not the only type of treatment out there for evidence-based treatment out there for children. Basically with TFCBT involves, especially with younger children, but ideally also with older kids like teenagers. It's really intended for children ages 3 to 18. And the ideal is for a parent or caregiver to be involved in the treatment. So it's not just a child coming in and then, hanging out with the therapist for an hour and then leaving the office. A lot of times there's a lot of chair moving, musical chairs kind of stuff, because maybe the child will come in for 20 minutes and then the child will go out and the parent will come in by themselves for 20 minutes and then they'll all come in together at the end. That it usually looks something like that. And there are different components. So the first step is assessment. So just trying to get a good idea. And I think most evidence-based trauma treatment, even for adults, include these components more or less. So the first step is assessment, getting a good idea of what those symptoms are. Also gives an idea of what we want to work toward in treatment. What are the goals? So for example, if they're refusing to go in the bathroom again, and that's a major problem, then that could be sort of a goal that will be worked on, for example. So once we get the assessment, TFCBT can be provided if the child, even if they don't have all the symptoms of PTSD, if they just have some of the symptoms, it can still be very effective and helpful. So usually if they have at least some symptoms or all of them of PTSD, then it usually is the recommended type of treatment for someone who is trained in that type of therapy. So then the next step is psychoeducation, and that involves teaching the child and the caregiver about what symptoms are, what PTSD is, and what the treatment is like. So they know what they're getting into, they know about how long it can be expected to take, they know who will be involved in it, and that kind of thing. We're also kind of starting the process of exposure as well. And exposure is the whole idea, and I think this is what can kind of cause people to fear going to therapy related to trauma or any kind of fear. It's a highly effective method of dealing with trauma or fears, but what it involves is exposing the person to what they fear. Now, of course, with a trauma, you're not going to, make them go in a car accident again or anything like that. So instead, what we would do is kind of make them think about it. So if the trauma was a car accident, might mention a car, or might mention riding in a car, or mention, going fast in a car, things like that. And the idea is that it's gradual. One of the analogies that we use in psychoeducation is we talk about a pool. And so with with TFCBT, you're not jumping into the deep end of this pool to just, take this trauma head on. What you do is you start at the shallow end, you feel it with your toe, and when you're comfortable, you can go in a little bit further, and you can wade in gradually. And we make sure that the person knows how to swim in the deep end before we bring them to the deep end. And what the deep end would be, I would think, would be really addressing that trauma head on. So like, let's talk about the car accident kind of situation, or, let's have you ride in a car. You have refused to ride in a car. We've had to walk. You've had to walk to all your sessions. Let's let you, give you a chance to ride in a car and see that it's safe, or that it's safe most of the time, that kind of thing. So that is what the exposure is. It's gradual exposure. So it's gradually talking about, seeing pictures of, or just dealing
This
with
is Heather.
the trauma. Yes?
I'm good.
Oh, I guess somebody
Okay.
is, I don't know if they're talking.
I'll just stop in and get it.
Heather, can you mute yourself, please? I don't know if I can mute her.
Okay. All right,
Sorry,
sounds
Ashley.
great. Thank you. Bye-bye.
That's okay. Happens to the best of us.
Okay, if everybody could just make sure they're on mute for us, please. Thank you.
Unless you have a question, then feel free to unmute and let me know. So that's with the gradual exposure component. And then the next step after psychoeducation is teaching relaxation strategies. And I try to tailor that to the individual, whether it's an adult or a child. With TFCBT, it would be with a child typically. So things like deep breathing, blowing up a balloon to help a child visualize what that looks like. Mindfulness strategies, a lot of the coping skills that we use in the WCCI meetings and events can be used as relaxation strategies for kids. Brain gym things, like was talked about last week. So that is the next step. And a lot of times I try to give something to the child that they can take home with them, whether it's a stress ball or a coping box, sort of like a toolbox or things like that. And then after relaxation, we talk about feelings. So try to make sure the person is educated about feelings, that they're able to say what their feelings are, recognize them, and know where they feel those feelings in their body. And then after we talk about the feelings, we then talk about thoughts and how our thoughts affect our feelings. So if you think, oh, cars are so dangerous, then we're going to feel scared when we're in a car. If instead we think, oh, car is a great way to get to the store really quick, we're not going to feel scared, So just kind of helping them understand that link. And we have some really neat strategies and techniques to help even really young children to understand that connection. Even a child as young as 3 can make the connection of, oh, if I think about it this way, I feel this way. If I think about it this way, I feel bad, or I feel better, or I feel worse, depending on how I think about it. And after talking about the cognitive coping, then the next thing is, and what we're doing gradually talking about the trauma. So doing it a little bit more and a little bit more each time. And the therapist has to get an idea of what's appropriate with the kids. So some kids are having more difficulty with that than others, and they're going to go a lot more slowly. Now there are some types of treatment that involve more forceful exposure, that's not as gradual, but that's not typically recommended. It's not recommended for children and only works sometimes. It's a very risky thing to do. It's not always effective with adults either. So that's definitely not the way that I practice, or I think most people practice. So there's gradual exposure. So example about cars, like how many people, or car accidents, how many people get in a car accident each year? How many people die from a car accident each year? What kinds of cars are the safest to ride in? Different things like that just get a child thinking about their trauma in sort of an indirect way without them having to directly confront it or address it. So after those components have been addressed, then there is the trauma narrative, and that is where a child has an opportunity to really process their trauma. And usually that is where the child is verbalizing what happened to them out loud, and the therapist is recording it. And that's so that the therapist can control the pace, so that the child's not doing it too quickly, or, so that they're like, okay, I was in a car and then I went to the hospital, and maybe that's all they tell you. And the therapist tries to really help them deal with it, identify it, process it a little bit more, for example. And that's where, there can be different strategies. Sometimes there are drawings that help a child to better express what's in their head, what's in their mind. They can do sculptures, play with Play-Doh or clay to kind of try to recreate the scene. Houses, play toys and things like that can be used to set that back up. And even, like I mentioned before, a comic book could be used. Well, there was a child who really loved comic books, and I heard about a therapist who had helped that child create a comic book of their trauma, and where he was the superhero, and he ended up conquering, that in some way. So really creative ways of doing it. And we get lots of great ideas from other therapists and from the experts in the field that can share these ideas with us. So after the trauma narrative, that's kind of the big part of it. And that's probably the part that makes it maybe in some ways more challenging than other types of therapy. You had mentioned, Denise, like if it might be more difficult or more serious or more challenging than other types of treatment. I think that a lot of different types of, I think treatment for anxiety in general can be uncomfortable and challenging. I don't know that it's a whole lot different than in how they experience it from like a phobia. So if someone has a phobia, I think they would also find it uncomfortable and challenging, but it can also be very helpful and effective. So I guess it's just really tailored to the individual, but I think because, ideally the therapist trying to make it fun also, sometimes of what's going on. They're not totally aware that this is so hard, but a lot of times they do become, and so with the gradual exposure, maybe they're not totally aware of what's happening, but of all the things that are taking place in their brains. But when we have the trauma narrative, a lot of times it hits them. And that's when a lot of times, I'll warn parents ahead of time, well, it might get harder. They might not want to come into the session, while they're talking about their trauma, because that's the really hard part. But I find that a lot of kids are really ready to, so they're starting to tell me about it before I'm even ready to get to that stage of the treatment. And usually after the first or second time they've come to me and told me about it, and we've sort of processed it, then it's like a downhill thing. I've found that most of the time the child addresses it directly and confronts it, and then it's not as hard anymore. And then it seems a lot easier for them to bring it up and talk about it. Typically, the trauma narrative does not include every single incident. So like if a child has had multiple traumas, I'm not asking them to tell me about every single thing, every single trauma they've experienced. Usually you're trying to tell them about, or I'm asking them about, okay, what's the worst time that happened? If it happened more than once, or if there was just one trauma, I'll say, tell me about the car accident. But we ask them to tell about the worst thing because that's probably the thing that is causing that particular event, is probably causing the most fear and the most symptoms. So if they can address that, then the other things will not be bothering them as much either. But that's hard to do, and it's something that I had to adjust to. Is okay, tell me about the worst thing that ever happened to you, and kind of watching the child go through this agony of talking about this trauma. So I really had to buy into the treatment in order to do it, to know that it's sort of like trying to take the splinter out. Like, I know we've got to remove the splinter. It's going to get infected if we don't. I'm sorry, it hurts even more to take it out, but then it can heal. And we use that analogy a lot. I use that analogy with parents and children, because that's a lot what it's like. Your emotions and your brain and your body need to be able to heal, and we sort of have to get this yucky stuff out first in order to let them.
Ashley,
yes,
it's Vicki again. If you have I'm a kindergarten teacher.
Mm-hmm.
If you have a child that's had a trauma and then they just come to school and talk about it, and it's one of those things that, it's made me uncomfortable, and then you don't know how do you guide them to, that's kind of stuff you talk about at home. I've had that happen, and I've been like a deer in the headlights. So what's the best way to help a child that's been traumatized? They just, kids that are 5 and 6 just talk about it sometimes. And when it comes out, I know it's supposed to, but when it's not really appropriate, how do you change the subject tactfully? What would you recommend?
That's a really good question. And I think there can be some concern with that. I've dealt with that with clients too, that you really don't want the other children in the classroom to experience some kind of vicarious trauma just from hearing about this, and the way they view their world can be altered just by hearing, oh, that happened to you? Well, can that happen to me? So that's definitely something you want to try to control, and I think there are a lot of ways to address it. I think certainly talking with a counselor, like letting them go talk with a counselor and letting the counselor address that, because you probably can't really do a whole lot in a classroom full of kids. It's not like you can sit down and say, well, let me tell you about this, when you're in the middle of teaching math or whatever. One thing to think about might be if you're able to reserve some time for that particular child to say, okay, well, I have, however long it is, 5 minutes or 10 minutes or during lunch, we're going to have this one time when, you can tell me whatever you want to tell me for that day, and you can tell me private things. So I don't want you to talk about private things, like bad things that have happened to you in the whole classroom, but you can come to me and tell me during this time. And then I think after you've been able to address it with that, then, maybe I don't know, I would guess like sending them if they keep on talking about it, trying to manage that very carefully and gently, but also firmly, like, no, this can't happen,
Right.
Whether it's through some kind of behavior management or letting them go somewhere else or something, and then of course, like encouraging them to get that treatment, get some therapy.
Thank you.
But yeah, is that helpful? That's just an idea of how to do that. And
Thank you.
and another idea too is maybe to let them write about it or draw it. I guess in kindergarten they're probably not going to be writing it, but letting them draw what happened, and then making sure they keep that paper private and they can show it to you and you can talk with them about it later or something like that. And that could be helpful for them too. But yeah, it's often something that when kids go through something awful like that, they really want to share it, and it's their story, and they can really get a lot of mastery by sharing it. And kind of, it's like talking about the monster in the closet. Once you can say there's a monster in the closet, then it's like, okay, now we know how to deal with this or how to work with it. And it can be the same way with trauma. So they're trying to get mastery over it in some way, but you have to be careful, because I think some kids who have experienced a lot of trauma also have realized that they can get attention that way, and that's what they want. And so they might get reinforced for telling this story and then learn to tell it more and more. So that's definitely a difficult situation to try to reverse with them. So the last few components of TFCBT are, after the trauma narrative, are just trying to help them learn safety skills. So if they've been in an unsafe situation before, helping kids learn and sometimes even role play or practice things they can do to make sure they stay safe in the future. And it just depends on the specific trauma. And then also how to have like kind of a healthy future in relationships, so if some traumas were related to trust of other people, if it was some kind of violent trauma, then, helping them learn how they can trust some people but not other people, and, figuring that out and being able to at least learn how to trust some people, outside of just their therapist and maybe their caregiver. So those are the main components, and all along through that process, I'm also meeting with the parent, getting information from them. And if the parent's having trouble trying to manage the child's behavior, especially if defiance is a major issue, sometimes that happens with a trauma, or irritability, trying to help that parent or caregiver, helping them to manage that, giving them ideas of, okay, let's try this, maybe you can try this. And so working with the parent. And then the child is also trying to share all that they're learning with their caregiver through the process. So they might share with them how much they've learned about car accidents, for example, or let me show you this relaxation strategy. I'm going to teach it to you, Mom, and then you can try it and see what you think. So it helps them to have mastery over those things they're learning and to reteach it to someone they care about. So it really helps them to learn, and it kind of reinforces those different skills and facts that they're learning.
Ashley, one of the myths about therapy is that it takes like years and years to be finished or whatever. And so is TFCBT, I'm sure it depends on the trauma and the child and a variety of things, but does it tend to be, I feel like one of the things I've heard about is it has to be done in 12 sessions. Like, is there a time limit? Is it a shorter process? How does that work?
Yeah, that's a great question. I'm glad you brought that up because I forgot to mention it. TFCBT is intended to last from 4 to 6 months. So 12 sessions might be a little bit short. It kind of depends on what's going on. I think probably for me around 3.5 to 4 months is probably the shortest length of time that it has taken. But that's 16 weeks. And so it might seem like a big commitment, but if the child's really suffering from a lot of symptoms, it's really not bad at all. And a lot of CBT or cognitive behavioral therapy is briefer and shorter term. And that's one reason I think why a lot of insurance companies like it too. They don't have to pay as much that way. But yeah, and the psychodynamic therapy is traditionally much longer, can take much longer, like years and years. And some trauma therapy, especially for adults, may take longer. But a lot of times for kids that it can be completed. Now, I have had clients that have graduated from TFCBT and they've gotten their certificate and their party and all that, but then they've ended up returning for some reason. Maybe they had a different trauma that happened, or there's just some unaddressed issues that kind of popped up unexpectedly later on. But usually when they return, I'll maybe see them for a month and that's it. And then they're done and they don't really need it anymore. So yeah, that's another benefit of it, is that it's really not too long. It's pretty short in the scheme of things, a half a year or less.
I don't know how much else you have to cover, but if you have a few minutes before you get done, I've started asking everyone, this sounds very intense, how you practice wellness for yourself, what you suggest for people who've never incorporated wellness. So you probably have some other things to cover, but if you can touch on that before we get done.
Yeah, I definitely planned on touching on that. I know I sent Denise and Candace a website, and I wanted to see if either of you could maybe pull that up. I think I'm just going to paste it into the chat here also, because I think I still have it.
So what I forgot is when I'm recording, I can't leave this screen in any way.
Okay.
So I can't pull it up, but there it is. You got it in.
Okay. Yeah, so the website I've put in here is for the North Carolina Child Treatment Program. It's the organization that trained me in TFCBT. And they have a really great feature, and this is just for North Carolina, so it doesn't include other states, unfortunately, but they have a great feature where you can search for a provider. And so wherever you are, if you're in Raleigh or if you're in Boone or wherever, you can search for a provider and in a specific type of treatment. And they have trained and rostered all kinds of different clinicians in lots of different evidence-based treatments. So TFCBT is just one of them. There's also parent-child interaction therapy, PCIT. There's another parent-related one. I'm forgetting the name of it. There's a group-oriented trauma treatment called Sparks. There are lots of different evidence-based treatment for different ages that you can find a clinician who has been rostered in that area. And also in that search option, there's also a way to find out where they practice and what kinds of insurance they take. So if the therapist takes Medicaid, or if they take Blue Cross Blue Shield, or whatever it might be, if they come into the home, or if they just work from the office, that kind of thing. And I think they're trying to update it now to include if the therapist provides telehealth, which is mainly what I'm doing at this point. So anyway, I just wanted to share that resource, and there are other resources there as well about types of evidence-based treatment. I think you can even maybe find links to research if you wanted to. So anyway, and there's a lot of there are a lot of websites, free websites that give lots of information as well, but that's a good one specific to treatment of trauma.
Great, thanks.
Yeah. So how I take care of myself, one thing that I learned, I guess, in graduate school was how to try to not take different cases home with me. So I tried to learn how to compartmentalize as well as I could. Like, I'm going to think about this when I'm in the office, and then I'm going to think about other things when I drive home, and maybe I'll try to think about it on my way home, but then I leave it in my car, and just try my best not to think about it when I'm at home. I'm a very verbal person, and I kind of process things by talking. So sometimes if something's really bothering me, the thing that probably helps me the most is talking with someone about it. So having another therapist or someone, and of course I wouldn't talk about a specific case like, oh, Jimmy, was really upset today. I would just talk about stuff generically, or, oh, I had a client that I had a hard time in that session, and I talk more about my own experiences with it to keep everything confidential. But I think talking about that helps. And I definitely believe in therapy, and so I don't hesitate to seek out a therapist if I feel like I need that, if my own personal issues are interfering, or maybe even if I have, encountered something in my work that seems to be affecting me personally. So I've definitely had therapy on and off, and it's really helped me a lot. I also have supervision, so I can talk with, I have a regular supervisor that I meet with to talk about things that are difficult. So this is how I deal with some of those really tough stories. But, I definitely haven't seen everything, although sometimes I feel like I have, or heard of everything. So every once in a while I run into a new case where I'm like, wow, this is hard, I've never heard of this, and I never could have imagined this. This is so awful. And that's something like I'll have a new thing to kind of deal with. So sometimes I kind of struggle to not take it home with me, but usually I find a way to sort of resolve it in my mind. And I often feel a little better knowing that I'm trying to help that person in some way. So that kind of makes me feel like I have some control in how they're doing, that I can maybe make a positive impact on them. I'm also really get a lot out of physical activity. So I have been exercising regularly. I've, without having to get out of the house and go to the office and get kids to a physical building for school. I have a little more time in my mornings to, get up at the same time, but try to exercise, and that helps a lot. I like to do all kinds of things like take walks and hikes and yoga and aerobics and different stuff like that. And then, a lot of the things that we've talked about, like just taking deep, slow breaths. I have learned progressive muscle relaxation, and that's something that I'll type that in the chat too, because it's kind of a big, long phrase. But that helps me sometimes. That's something I had to learn how to provide to people when I was in grad school, and it helps me a lot too. So that's something I enjoy doing if I'm having a particularly rough moment. And then of course talking with friends, having contact with friends and family also, and playing, playing with my kids. I'm not really good at playing on my own. I don't get a bunch of toys out by myself, of course, but my kids kind of inspire the playfulness in me, and so I enjoy playing with them sometimes. We made a fort the other day. That kind of thing is helpful. I think that play is a great way to battle seriousness and stress.
Well, that's interesting that you point that out, because somebody said one of their myths is, that therapy is a lot of hard work and not much fun. So I think the theme I keep hearing from people is finding the joy in things, even when things are hard. And
yes,
another thing we keep trying to reinforce is there's this notion that self-care or wellness has to take an hour and cost a certain amount of money and have certain equipment. when it actually is really your perspective and finding those
Mhm.
moments of joy even when things are hard. So that's a good
Mhm.
point, to look for the fun and try to find the joy in things.
Yes.
If
Yes.
you have started working with somebody who does no wellness or self-care whatsoever, do you have any tips on how to get started with that?
If I'm working with somebody who isn't really practicing self-care very well, right?
Yeah.
Well, a big component, I mean, I was trained in cognitive behavioral therapy. You hear me mentioning that a lot. So that's kind of my main base of treatment, but I do offer some other types of treatment as well. But the big part of, the behavioral part is homework. So a lot of times I assign homework. So I'll make sure people know, I'll make sure people are familiar with, a coping skill like deep breathing, for example, or progressive muscle relaxation, and say, okay, I want you to practice this. I want you to practice it every day, or I want you to practice it at least 2 or 3 times a week. And if they come back and they haven't, I said, okay, well, get out your phone. We're going to put a reminder in to do this, or let's put it in your calendar. So phones are really helpful for that, putting in those reminders. Sometimes I'll email them, it's like, oh, here's a great, YouTube link on progressive muscle relaxation. I think somebody had just sent something out with that. So yeah, I try to really encourage that. And then ultimately it's up to them, but just trying to educate them on the benefits of that. A lot of times when people practice it in the session, they enjoy it and it feels so good that they want to recreate that. They want to make it happen again and not, have to come into the office to do it. So I talk with them about how they can do that other places. They can do it in their bed or at home, or even some things we can do in the car, while driving, that kind of thing.
Yeah, so you mentioned in the chat, Candace posted that there's a lot of recordings, YouTube and elsewhere, of guided progressive muscle relaxation, easy to use. And then Maggie said, she put a link from YouTube and said she had shared it to save on your device so it's easy to pull up, which is such a great tip. I know there's apps you can have on your phone. Uh-oh, I put something on this screen. I hope when okay, sometimes when I want to hit the X, I'm like, please don't go anywhere. That you can have on your phone, because we're all on our phones all the time. So it's easy to pull up and maybe easier for you to do. We had somebody in our car just a few minutes ago. And then last week we had somebody in our car, I think. And so sometimes when it's on our phone, we're more apt to use it than if we have to go into a room in our house with a certain kind of clothing, and it has to be dark and all those other quantifiers.
Mm-hmm. Yes. Yeah. Thank you for sharing that, Maggie. I'll definitely, I'd like to look at that one. Now the chats are not typically available after the live Zoom session, are they?
We have actually been copying them. So we have a copy of who attends. So we have been copying them for ourselves. And then if anybody wanted any part of, what had been put in the chat, they're welcome to email us and ask for that. And we can send them, because we are starting to keep that on file. As we get more depth at managing all this, we've started copying the chats.
Well, I've watched several recordings that I haven't been able to make it in the middle of the day. So I really appreciate other people, participating in this, and want to let you know, even if I'm not there, I've watched them when I can later.
Oh, great. Thank you. So we've got about 5 minutes. If anybody wants to ask any questions or share any thoughts about anything that Ashley said or something that we haven't covered yet. I know I'd asked Ashley, is it more intense for the child? I'm wondering for you as the professional, is trauma-focused CBT more intense for the practitioner than a traditional kind of therapy? It seems like
yes, I would think so. Yeah, it definitely was. And, and I really enjoyed working at the CAC, but I was really grateful when I went on to work at our business, just to have more variety, and I still do treat kids for trauma, and adults as well. But it's more balanced, so it's not like my full caseload, and it's not all that I'm doing, and that helps. I think it would be hard to work in that for a long period of time. I mean, it's definitely doable with lots of supervision and support, but yeah, definitely hearing a lot of hard stories and that kind of thing. So it is definitely challenging. It's wears on the emotions for sure. I definitely cried a lot more after I started providing TFCBT than before. So, but that's part of it is just dealing with the emotions and trying to process those.
Well, and I like that you said that, because I think sometimes, I know this is true for teachers and social workers, I think a lot of service providers and people who interact, is that somehow there was this expectation created that we're all supposed to manage this without blinking an eye, without faltering in our steps. And so just to know that it can be very intense and challenging and stressful and difficult and rewarding and satisfying, and that there'll be times when you were dealing with our own emotions. You mentioned vicarious trauma, secondary trauma, and that's okay. And that doesn't mean that you're not supposed to be doing it. It just means that you need some extra support yourself. So that's a good point.
Yep.
So any other things that you want to share with us before we let you go? We'll go about 3 minutes, and we appreciate very much you taking time out of your busy schedule to be with us.
I'm happy to. I appreciate being asked and invited. I'm honored to be part of this. And I appreciate everybody who came. Thank you so much. And, Denise knows how to reach me if anybody has further questions or follow-up or anything. And I'll definitely talk with my husband, Craig, about, maybe sharing a little about what he does with the sex offender treatment and everything, because I think that it's just really interesting to hear about too. It's kind of an interesting topic.
Well, we appreciate you lobbying for us with him. If he even wanted to come with somebody else, so he wasn't the only person, if he feels like he might be on a hot seat or something, maybe coming with somebody else might make it a more pleasurable experience for him. And now you can testify to how great it was and how good a care we'll take of him. So lots of comments in the chat about thanking you for spending time with us, and it's good to see you, and that we would love to hear from Craig as well. So thanks again, Ashley. It was good to spend time with you. I hope you have a good rest of the day.
Thank you. I hope you all do too. Appreciate it, Denise.
Okay, thanks. See you soon.
Okay. Bye.
Bye.